topic, theories of impression making and impression procedures for complete dentures. The most important topic which has to be understood from the very first day, because the first impression is your last impression, but that proverb doesn't work with prosthodontists. Let's see what is impression. So impression is defined as a negative likeliness or copy of a reverse of the surface of an object. So what will be an impression for our oral cavity? It will be a reverse of a negative copy likeliness of what? Of the teeth, of the mucosa, of the hard palate. So a negativity of that will be known as the negative of that will be known as the impressions of oral cavity. Complete denture impression. A complete denture impression will be negative registration of the entire denture bearing area, stabilizing and border seal area which is present in the edentulous mouth when the patient walks to us. Coming to preliminary impression, basically a complete denture impressions has to be further not classified but stepped out into two types. Primary impression, also known as preliminary impression, also known as diagnostic impression, and the final impression. So what is a preliminary impression? An impression which is made in the patient's mouth for the diagnostic purpose or making of the cast or the special tray is known as preliminary impression. Definition of final impression: it is the final impression which is made from which the cast is going to be prepared. Which cast? The master cast. The final cast is going to be prepared. Impression material. So it is any substance or a combination of substances maybe which is made used to make the impression in the oral cavity will be known as impression materials. Coming to the anatomical landmarks in the maxilla, to make an impression we should be able to know different landmarks in the maxilla, and most important, not only know the landmarks but also its importance and what it is its capacity towards bearing a complete denture. So it is further classified into supporting structures, limiting structures, relief areas. So first we will see the supporting structures. The supporting structures, that means what does the word mean? Supporting, whatever supports the denture, right? So that can be again primary stress bearing area and a secondary stress bearing area. Stress bearing area, the name itself suggests us what we want to understand from it. Stress which can be bared by the bone or whatever, any anatomy which can bear the stress primarily is called the primary stress bearing area. Little less it can bear, that will be called as secondary stress bearing area. Now how are we going to classify this? Under which is to be called as primary stress bearing area, which will be called as secondary stress bearing area. So two reasons to classify anything under primary stress bearing area is: number one, it should have a cortical bone and not cancellous bone. I again repeat, cortical bone, not cancellous bone. That means the bone which is hard, not the soft spongy bones. Second criteria is the trabecular pattern that should be there is perpendicular to the force which is directed by the mastication. So now what will happen? Anything which is perpendicular, the force will be directed perpendicular. So the stress can be taken over by the beneath structure, and the beneath what we have cortical bone. So all these things are coordinating it towards a primary stress bearing area. Little advert from this particular thing. Little not 90 degree, little not perpendicular, little not cortical, little more cancellous. A mixture of these kind of properties, or a submucosa which is covering over that particular area is little thick, those will consider under secondary stress bearing area. So let's see what are in the primary stress bearing area. We have a hard palate. We have the posterolateral slopes of the residual-alveolar ridge, not entire residual-alveolar ridge, only the posterior-alveolar slope, posterior lateral slopes. Secondary stress bearing area are the rugae and of course the maxillary tuberosity and alveolar tubercle. So now coming to the limiting structures. Limiting structures are, what do we understand by limiting structure? The word suggests limiting the denture. Till that our denture is going to limit its extensions. So what are those? Labial frenum, labial vestibule, buccal frenum, buccal vestibule, hamular notch, and most important is posterior palatal seal area. What are the relief areas? Again, as the name suggests, let's make prosthodontics more easy and more conceptual rather than memorizing it. So relief area, relief, anything which is going to give relief, which requires relief, means those are fragile areas. Those are the areas which cannot be given pressure on. So what are those? Incisive papilla, mid-palatine raphe, and of course fovea palatini. One more relief area which is missing over there can be a tori if it is present. That has also to be relieved if a moderate or a small tori present. Coming to the supporting structures first. Hard palate. Hard palate plays a very important role in maxillary denture based area. The maxillary complete denture takes its entire support from hard palate. 90% of the support that it gains is from the hard palate. Now what is the reason behind that? The hard palate is all cortical bone. The submucosa over that is thin. So it is taking up more pressure from the bone. So the denture is going to be more stable in that particular position. So hard palate was considered to be primary stress bearing area. Again, let's go back to the anatomy. The hard palate is straight. So the force acting is again perpendicular, almost straight in maximum cases. Somewhere where the high vault, palatal vault is there, that's a different issue altogether. There we lose our stability of the dentures. The reason is that that cannot act as a primary stress bearing area. In those areas, we have to increase the amount of spacer that we are supposed to use. So coming to different hard palate sections are the front area, as we can see, which is in green color. That is a secondary stress bearing area. That is the area where rugae is present. We'll talk about rugae in some time. Hard palate, which is the primary stress bearing area, is the posterolateral slope. Name suggests posterolateral. Posteriorly lateral slopes from the residual ridge, that particular area. Now why that particular area? Because that is perpendicular, number one. Because that particular section is not very highly placed, residual ridge is left in that particular place near to maxillary tuberosity, ahead of maxillary tuberosity basically. So that particular section is the primary stress bearing area. Once we take a cross section of a hard palate, what we see is the maximum places different kind of variety and varied depth of the hard palate we can see. That means the bone not everywhere is the same, even in hard palate. So cortical bone is there, true, but cortical bone has varying depth, and the tissues which is over this particular area is thin submucosa. So again the denture is not going to move, stability is maintained, so it is again useful for us. Coming to the residual ridge. Most importantly, a residual ridge has three basic layers: a mucosa, a submucosa, and the bone beneath it. Now the residual ridge, it has a bone. Upon the bone there will be periodontium. On the periodontium there will be some salivary glands. There will be minor salivary, major salivary glands. Then there comes the submucosa. Ending of submucosa to the mucosa is always with a basement membrane. Then there will be all kind of cellular layers like stratum granulosa and stratum cellulotum, stratum basale. All these layers will be there, and above everything there will be opening of the ducts which is present down the salivary gland ducts. So these are the three different mucosa, submucosa, and the bone layers. And most importantly, in a residual ridge, the most important thing that we see is sufficient amount of thick submucosa is present. So what will happening because of this sufficient amount of thick submucosa? It is not allowing the pressure to go beneath the bone. Pressure is not on the bone will not resorb fastly. So that is one advantage of the submucosa, the thick submucosa which is present. Coming to the next part of residual ridges, as we can see on the crest and on the sides, we have these loose areolar tissues, the mucosa. So once we have a denture on that mucosa is resilient, it can be movable. So our denture is not also going to be supportively sticking over that particular place. So that is another reason why we do not take it consideration of the side bone. Now what things that you need to observe here is the trabecular patterns. We can see those trabecular patterns are perpendicular to the cross section. There is a cross section, so perpendicular to the force acting of the mastication, it is perpendicular. So that is another reason that it is considered a primary stress bearing area, but not the crest of the ridge, of course. So the next thing that we will talk about is rugae. As we told, rugae is a secondary stress bearing area. What exactly is a rugae? So rugae is nothing but it is a mucosal fold which is of the palatal mucosa. So it's a mucosal fold of palatal mucosa. Now how is it placed? We all know in the anterior region of the palate we have all those snaky shaped, S-shaped structures that is called the rugae. Now, why is it considered secondary stress bearing area and what is its important in the denture? The denture, it is important because it doesn't allow the denture for forward motion or forward displacement. So it prevents the forward displacement of the denture. Why is it secondary stress bearing area? Because though the bone beneath it is cortical bone, though it has a cortical bone, the rugae has a property to rebound. So this rebound nature of the rugae can displace our denture. So that is the reason, though since the bone is cortical, we cannot accept it out from the stress bearing area. But since the submucosa is not very thin over there, it is hard, it is a mucosal folding which has a property of rebound. So we had to place it under secondary stress bearing area. Coming next to the maxillary tuberosity. Where is this maxillary tuberosity placed? In the region behind second and third molar regions. That prominence part is called maxillary tuberosity, which ends itself in the, then there is a maxillary tuberosity, then it ends in the alveolar tubercle. There is this bony prominence kind of thing which is alveolar tubercle. Important and very interesting fact to know is this maxillary tuberosity and alveolar tubercle, this area do not resorb very easily. It's the least likely area to resorb. So we need to take our denture base till the end of the maxillary tuberosity. So that is very important. So what is this alveolar tubercle which is present behind the maxillary tuberosity? It's a bony prominence. So there are different walls. So medial and lateral wall has some function to resist and there is a posterior wall that will have some function. What will the medial and the lateral wall do? It will resist the horizontal movement or the torquing forces, the horizontal tipping forces. What will the posterior wall do? It will resist the posterior movement in the anterior direction. Movement towards posterior will be and what will resist in the denture will resist the anterior movement it will resist. So this is a function of alveolar tubercle. The two different walls have two different functions. The medial lateral functions to prevent the torquing movement, the horizontal disability, and the posterior wall will not allow the denture to move forward. So coming to the limiting structure, labial frenum. So labial frenum is a fibrous band. The fibrous band which is running from the residual alveolar ridge to that of the lip. Now this can be broad, this can be narrow, this can be thick, this can be thin, this can be long as well. What is our basic motto to know the labial frenum? That first thing is that it doesn't have any muscle attachment. So it's a muscular fibrous band. So what is the advantage for us? That is a passive frenum. It cannot dislodge our denture. It is not active. Unlike that of mandible. We will come across that. So first thing is that it is a passive frenum. Secondly, this particular labial frenum has to be recorded in the denture. That recording of the labial frenum anatomically in the denture will be known as labial notch. So that notch has to be long enough or deep enough to accommodate the entire length of the frenum, but it is not supposed to be wide, because once it is wide, it is again losing out the atmospheric sealing pressure of the denture with that of the oral mucosa after fabrication of denture. So that we are supposed to keep it. So the next is labial vestibule. So labial vestibule is that portion in the oral cavity which is bounded on one side with teeth, gingiva, on the other side with lips and cheeks. So where is it starting from? It is that area from the buccal frenum to that of the labial frenum. That is called the labial vestibule. Now we all know that it is lined by the lining mucosa. But do we all know that what is the muscle which is exacting its effect on this particular section? That is orbicularis oris. Where is this muscle present? This area. So it is horizontally running muscle. We all know it is a horizontally running muscle. So what happens if you have not recorded the space for orbicularis oris in a denture while making an impression? That will dislodge the denture while we are speaking, while we are doing mastication or any other respective habits with our mouth. That will dislodge the particular denture. Coming the next is buccal frenum. Now buccal frenum is again the mucosal folds or the muscles. There are three different muscles which come and organizes in that particular area. That is effects that gives its effect on the denture. So we need to relieve those all muscles and make the impression according to how that muscle is running towards the particular area which is called the buccal frenum. Now, there are three muscles. What are the three muscles? Orbicularis oris, which is coming from anteriorly and horizontally. Levator anguli oris, this muscle, levator anguli oris, which is also running horizontally. And buccinator, which is coming from behind. So, once we are making an impression, the movement should be upward, downward, and backward, and then forward. This is how the movement should be to record a buccal frenum because of the muscles which are associated with it. Coming to the next is the buccal vestibule. Now, buccal vestibule, it runs from buccal frenum, and where does it end? It ends into the hamular notch section. So, from buccal frenum to that hamular notch, that depression, that area, which is one side bounded with the help of the teeth and the gingiva, other side with the cheek and the cheeks itself. So, that area is called the buccal vestibule. Now, this buccal vestibule, what are the muscles which is over there? One is masseter, which is here. One is buccinator, which was there, we spoke about before. So, contraction of buccinator is going to affect how much space is available for buccal vestibule. Position of the mandible is going to affect, and the amount of bone lost from maxilla is also going to affect. How are these coordinated? Let's understand that. Buccinator, it is there beneath the muscle, beneath that of the particular area, so it is running horizontally. So, it is going to put its pressure. Now, our mandible, how much it is going inside, what will decide that? How much maxilla is resorbed, that much the mandible can go and hit that particular area, hit that particular section. And the position of the mandible, how mandible is anteriorly placed, so the space will be less. If the mandible is resting in the glenoid fossa, space will be more. So, all this coordinated way will decide the size of the vestibule, that is mostly the buccal vestibule. So, one more important fact that we need to know about buccal vestibule is when we are recording it, we need to ask the patient to do sideways movement so that the coronoid notch is actually hitting that particular area, and in the buccal flange of the denture, there is a coronoid notch which is created so that it gives space for the coronoid to come and sit whenever there is an anterior movement or sideways movement without dislodging the denture. So, that is a very important step while fabricating and making impression in denture. Coming to hamular notch. Hamular notch is that area which is posterior to the maxillary tuberosity. It is a depression where it is a limiting structure as well, beyond which your denture should not extend, because beyond that will come the alveolar tubercle and that will start dislodging the denture. So, this hamular notch, the main important structure which is coming here is the pterygomandibular ligament. So, why is that so? Because the hamular notch is nothing but it is the extension of the posterior pterygoid plate. So, before that it is stopping. So, it is also an extension of the distolingual limitation of your denture. The muscle which is present in the hamular notch region is a loose areolar connective tissue. So, what is it helpful in? Because this area is near to posterior palatal seal, when the denture is going to give pressure towards the posterior palatal seal, it will not dislodge because it is a loose alveolar tissue. So, it will help in retention of the denture. Coming to what exactly is posterior palatal seal, which we are talking from long time. So, posterior palatal seal area is defined as, posterior palatal seal is the soft tissue at or along the junction of hard and soft palate on which the denture retention is aid. But how denture retention will be aid? Where pressure within the physiological limit in that particular section can be applied. So, that is particularly defined by GPT 8 by, it is a soft tissue at or along the junction of hard and soft palate on which the pressure within the physiological limits can be applied to aid in the retention of the denture. It was further divided into two parts, that is post-palatal seal and pterygomaxillary seal. So, it is further divided into two parts, post-palatal seal and pterygomaxillary seal. So, post-palatal seal is the section which is in between the hard palate, we can see, and pterygomaxillary seal is 3 to 4 mm before the mucogingival junction. So, this all along together makes the posterior palatal seal, both together. And most important thing is what is the shape of this. So, it is in a cupid's bow shape. You can all see it is in a cupid's bow shape. The post-palatal seal plus the pterygomaxillary seal both together comprises of the posterior palatal seal. Now, there were different conflicts which came up So there also came something which was two different schools of thought. So there's something which came as a vibrating line. So what was vibrating line? So vibrating line is that imaginary line across the posterior part of the palate, which is making a division between the movable part of the soft palate and the immovable part of the soft palate, identified which is movable onto the tissues. Very confusing. A vibrating line is nothing but a soft palate has two different parts, a movable part and an immovable part. Immovable part of the soft palate is with the hard palate, and movable part of the soft palate is after the hard palate, the uvula that we see. So the junction between these two were termed as a vibrating line. That vibrating line was further classified into two different types, anterior vibrating line and posterior vibrating line. So anterior vibrating line, so towards the hard palate, so that was between the hard palate and immovable part of soft palate. Posterior vibrating line was between the movable part of soft palate to that of immovable part of soft palate. So it is a junction of all together the hard and the soft palate where it is meeting. That section was totally known as posterior palatal seal. Recording of this particular thing is to be done by asking the patient to look down and give Valsalva manual. What is that? We ask the patient to close the nostrils and give pressure of the air through the nose itself. So that will record that particular area. Now that is Cupid's bow. That varies from patient to patient. It can be Cupid's bow, it can be flat in many patients. There are different designs which are given, butterfly shape, bead with butterfly, double bead with butterfly. Different shapes of posterior palatal seal is there. It is not necessary that all the patient will have Cupid's bow shape. So coming to the next is incisive papilla. So what is incisive papilla? It is a pad of fibrous connective tissue overlying the nasopalatine duct and the canal. The nasopalatine duct and the canal is orifice. We can see the white orifice. So there is the nasopalatine nerves and vessels which comes out and goes in. So what is more important in this section is that fibrous connective tissue which is there has to be relieved. Why is it important to relieve that particular? Because if not relieved, the denture can put a pressure onto the nasopalatine nerves and vessels, which can cause damage to the nerves and vessels and also can cause paresthesia. So that is the relief is important. Coming to mid-palatine raphe. Mid-palatine raphe, as we can see, it extends from the incisive papilla to down of the hard palate. Now again, why is mid-palatine area needs relief at times? Selective relief is required. Why? Because the thin mucosa which is present overlying this particular bone makes it nearer to the cortical bone. So the pressure in that particular area will be hampering with the resorption of the bone. And the mucosa also which is present is very thin. So instant relief and selective relief at least is required while we are fabricating a denture or while we are making an impression with a custom tray. Coming to fovea palatina. Fovea palatina is nothing but those two dots which we can see down. That is the two glands, the coalescence of glands that is present in almost all patients. So there again, should that be inside the denture or should that be outside the denture? That is the big question. It should always be kept inside the denture because the denture extension should be behind till that. So that should be included in the denture. And why is that so? Because it releases the mucous glands are there, so some amount of saliva will be released and that saliva will help in interfacial surface tension, another property to give retention of the denture. So how much beyond should we extend our denture? So that is 1 to 2 mm, minimum 1 to 2 mm and maximum not more than 2.5 mm beyond fovea palatina. Coming up to the anatomical landmarks in the mandible. Same again, supporting structures. So here the supporting structure is buccal shelf area. We'll see what is it. Residual alveolar ridge as usual. The limiting structures will be as same as that of maxilla except posterior palatal seal which is not present here. Instead of that we will have retromolar pad. We will have pterygomandibular raphe. Recently retromolar pad is also considered as a supporting structures according to the new voucher. Relief area, crest of the alveolar ridge, mental foramen. Now let's see one by one supporting structures. The buccal shelf area. Now the buccal shelf area is the area which is lined medially by orbicular crest of the residual ridge, laterally by external oblique ridge and distally by retromolar pad. So this is that area which is on the lateral sides of the mandible on the posteriorly. Now why is that considered? Because that is one area when you see in your mouth or in your patient's mouth, that is the area which is perpendicular to the trabecular pattern, or the bone itself is perpendicular to the long axis of the force. So it is making it as a primary stress bearing area, and moreover there is this muscle pull, constant muscle pull, reason for which even the retromolar pad, since there is an active muscle pull all the time, resorption rate is less over there. So that was the reason that nowadays Boucher has specially considered it to be a supporting structure, that is a stress bearing area. Coming to the next is the limiting structures. The limiting structure, the first is labial frenum. Labial frenum, unlike of maxilla, mandibular labial frenum is an active one. So relief of the mandibular labial frenum is very important, since if it is not relieved, it will displace the denture as soon as the denture is placed in the mouth. So labial frenum, what are the muscles which is there with the labial vestibule? That is orbicularis oris and mentalis. Now this labial vestibule, it extends from labial frenum to that of the buccal frenum. So that area which is lined on one side with that of the teeth, gingiva, but the other side with the cheek and the lips. The orbicularis oris and the mentalis. We know mentalis muscle in many patients. This is the mentalis muscle. In many patients it is very active. So that particular space of the labial vestibule will be decided by the action of mentalis muscle and the orbicularis muscle, which is circularly oriented around the mouth. So buccal frenum is the mucosal fold again which is coming up from the buccal vestibule and ending towards the ridge of crest of the ridge. Now this buccal frenum, which is the muscle which is dominating it, the muscle is depressor anguli oris. Like in case of maxilla, it was levator anguli oris. Down here, since it's mandible, we have the depressor anguli oris muscle which is dominating this particular region. So again, making an impression, we need to keep in mind about buccal frenum, relieve it, because later on if this is not relieved, this can give dislodging the denture. What are the different size and shapes of it? It can be wide, it can be narrow shape, it can be U shape, it can be sharp V shape, it can be 1, it can be 2. So depending on patient to patient, but main important thing is we need to relieve it. Coming to buccal vestibule. So buccal vestibule is that section again from buccal frenum to that of the retromolar pad. Now this particular area is mostly covered with buccinator. The muscle buccinator is all here. So it influences this particular section. Now this buccinator, as and when it gives pressure, the buccal vestibule will decrease. And also this buccinator, when it gives pressure, what is there beneath it? Masseter muscle. So it hits the masseter, and that masseter makes an impression onto the denture bearing impression what we are making on the denture. That particular is called the masseteric notch. So while recording the mandibular denture or making an impression, we need to record that masseteric notch. How will that be recorded? We need to make it active. So with the forcefully fingers, index fingers, you are supposed to open the mandible, asking the patient to close it forcefully, and you are depressing it down. So when the muscles are getting active, the buccinator will hit the masseter, and the masseter will in turn hit the flange, and then it will be masseteric notch will be created. So the next is lingual frenum. So lingual frenum is the center of the genioglossus muscle. We know the fan-shaped muscle. So it is the center of the genioglossus muscle, and this lingual frenum is attached to the tongue. So if this is very highly attached, it is going to restrict the tongue movement. So that is condition is called tongue tie. So in those cases, you need to go for pre-prosthetic surgeries, as we had discussed earlier. Similarly, if the tongue, this particular lingual frenum, which is there, while making an impression, we need to relieve it. Relieve it, record it. Relieve where? In the denture. So the polished surface will be there. You have to relieve the polished surface as well as the tissue area surfaces for the lingual frenum. Once if it is not relieved, again the action, because it is concentrated and directly connected to that of the tongue, the action will displace the denture. Coming to the most important section of mandible, that is alveolingual sulcus. Very confusing, very interesting as well. Alveolingual sulcus. What is the extension? Where is it extended? Why is it there? how much should we keep it, how much should we have to record within that. Very questions among these comes up when alveolingual sulcus comes into picture. First of all, to understand where it is, very basic, simple, with the definition we will go. Alveolingual sulcus. Between the alveolus, that is a ridge, and the lingual border, that is your floor of the mouth, the place which is present, the sulcus which is present, that is alveolingual sulcus. So everything is in the lingual section, the floor of the mouth, one side, on tongue on the one side, and on the other side is the residual alveolar ridge. Now where it extends from the lingual frenum to end of the retromolar pad or retromylohyoid curtain. Now it is divided into three sections. Since it's a long area, we divide into three sections: the anterior part, the middle part, and the posterior. The anterior part is also known as sublingual crescent area or the lingual fold. The middle vestibule is called the MYLOHYOID region, and the posterior vestibule will be called as distal lingual sulcus or also known as lateral throat form. Coming to the anterior region, where it is extending from, it is extending from that of the lingual frenum to that of pre-mylohyoid fossa. It is not extending from where mylohyoid ridge has started. Where is the middle portion then? It is in the mylohyoid region. So from the pre-mylohyoid fossa to the post-mylohyoid region or the distal of mylohyoid ridge, it is ending over there. And the posterior section will be post-mylohyoid ridge or distal to mylohyoid ridge till the end, retromylohyoid curtain. This is also called the lateral throat form area. Now coming to the anterior section. Here, which muscle will be acting more? Genioglossus, because that is a muscle of the tongue which is putting its effect on it. Also mylohyoid muscle which will act in the middle section. So mylohyoid muscle, if it is active, we need to even record that. We need to record the place beneath the mylohyoid ridge so as to gain retention. Thirdly, the action of the tongue with the mylohyoid, that also gets activated once we raise the floor of the mouth. That has to be recorded. But mylohyoid muscle has no action over the posterior end or the posterior region or the lateral throat form region or the distal lingual flange region. Now this distal lingual flange, we can see it's an S shape. The reason of that S shape is the tongue muscle is very strong and there is a superior constrictor muscle which is coming over there. So what it does is these tongue muscles give constant pressure to the superior constrictor muscle, making it to bend typically in the size of S, since the alveolar bone in that particular region ends in the lateral throat form section. But there is no influence absolutely of mylohyoid muscle in that particular region. Coming up next to the retromylehyoid fossa. Earlier, before the new Boucher edition had come up, this was considered under the limiting structure. For now, recently we have considered this into the primary stress bearing area. Anatomy remained the same. What made it change? So the thing what made it change was the bone beneath that is cortical bone, accepted, but there is a constant pull of the muscles which is present over this particular region, the retromylehyoid fossa. So the constant pull will not allow anything to give pressure beneath the muscle, the pressure to pass on from the muscle to the bone. So resorption is not going to happen. So in that way, retromylehyoid fossa is considered now in the primary stress bearing area. Now let's see what is it bounded by. So it is bounded posterolaterally with the help of superior constrictor muscles, posteromedially with that of the tongue. Anteriorly there is the retromylohyoid curtain or the posterior part of the mylohyoid ridge, and posteriorly we have the pterygomandibular raphe. What is there beneath? Submandibular gland. Coming to sublingual gland region. Where is the sublingual gland region present? This is present beneath the second premolar section. Second premolar, beneath that and above that of the mylohyoid ridge is the sublingual gland present. When the floor of the mouth raises up, this gland also comes near to that of the crest of the ridge. So recording of this particular area is very important, because lingual frenum, if it comes up, even this gland comes up. So we need to record the lingual frenum in its active position. Coming to retromolar pad area, we have spoken before this about this, that it is posteriorly with the tendon of temporalis. It is medially with that of the tongue, laterally with that of the buccinator. Medially there is also superior constrictor which is there, and this constant pull of all this muscle is not allowing the bone beneath that to resolve, because all the pressure is being taken up by the constant pull of the muscles. Coming to pterygomandibular raphe, as the name suggests, it is that raphe, it is that range of mucosal folds of muscle which is running from the maxilla to that of mandible. So from where of maxilla? From the pterygoid plate of the maxilla to where of the mandible? To that of the posterior part of the mandible beneath the retromolar pad. So that is a pterygomandibular raphe. What is the importance of this pterygomandibular raphe? A denture should not extend beyond this pterygomandibular raphe, because once we open the mouth, this pterygomandibular raphe gets taut. So when this is getting taut, it is getting active. It will displace the denture anteriorly. So we need to record it and not place our denture beneath that. Now superior constrictor is inserted posterior-medially, as we know, and buccinator is inserted anterolaterally, anteromedially. Buccinator which is inserted anteromedially. So when this lateral border and the medial border on the posterior and the anterior is secured, so what happens is our denture base should not extend beyond that, because all these muscles will give a pressure towards the denture and will tend to lift our denture. So this mylohyoid ridge runs anteriorly. We can see in the front, the genial tubercle, it is nearer to the inferior border of mandible. Posteriorly, it flushes out with the residual alveolar ridge. Now, relief of this particular mylohyoid ridge is necessary if it is very sharp. If it is deep undercut is present beneath this, relief of this is very important. If not relief, pre-prosthetic surgery is the best thing to reduce the mylohyoid ridge in this particular region. Coming to the next, which is the mental foramen, which is present between the first and the second premolar. Now, Weichel and Scoop did a study and found out in an OPG, if we see a mental foramen of a normal young human being, it has a ratio that the mental foramen to the inferior border is X. So 3 times distance is present from the mental foramen to the above the crest of the ridge. So while resorption pattern can be calculated with it, right? So X is to 3X is for the normal people. So if in the OPG of an old person we see that mental foramen is in between, that is X is equal to X, that means the resorption has happened twice. Twice as the rate of resorption has happened. So this is how we can find out the rate of resorption with the help of mental foramen. Most important, you need to also relieve the mental foramen, because inferior alveolar nerve gives out a branch, the mental nerve branch from this particular region, which is lying in between first and second premolar. Thank you.